Hi, everyone. I'm Graham. I'm here with Matt. We're the co-directors of the London Centre for Applied Psychology. And today we're focusing on addiction, what addiction is, how we treat it, and what the evidence shows about what works in working with clients with addictions. But Matt, let's start by definitions. Let's define our terms. What do we mean when we talk about addiction?
It's quite a simple definition offered up by the NHS, which I quite like. It's probably as good a place to start as any. So addiction is not having control over doing, taking, or using something to the point where it can be harmful to you.
And does everyone agree on that definition, or is there some disagreement?
I think broadly there's agreement on it. So if you're thinking of one of the sort of big names in addiction, if you're thinking about 12-step recovery, kind of 12-step program, the things like AA and NA and Gamblers Anonymous, so their definition is a physical compulsion coupled with a mental obsession. So sort of slightly different vocabulary. In the trauma literature, that sort of broadly tells us that addicts are often suffering from trauma, neglect, abuse, and that addicts are essentially people who hate how they feel, that addiction originates as an attempt to solve the problem of emotional pain. There's a really nice, really concise definition from someone called Maya Salovitz, and she's written one of the best books on addiction, I think. It's called Unbroken Brain, and she offers a 5-word definition, which is compulsive behaviour despite negative consequences, and that just about gets it for me.
Yeah, it brings the word compulsive into the equation, doesn't it? So when we talk about compulsions and compulsive behavior, or other words like dependency or disorders, is that same thing as addictions? Do we mean the same thing?
I think so, yeah. I mean, I think they're all legitimate terms. I'm not sure how much those terms matter. I think perhaps they do in some contexts, and perhaps they do for some people. But I think for most people who've been in active addiction or are serious about their recovery, truthfully, they got bigger things to worry about.
Right. Okay. So let's get a bit more specific. What really counts as an addiction? So something like internet use, gaming, porn use, can that be an addiction?
Yeah, I think my personal view is that it can. So the NHS, if we come back there, lists things like work, exercise, gaming, the internet, and even shopping as activities that people can get addicted to. The DSM, the Diagnostic and Statistical Manual, that tends to be sort of sometimes referred to as the psychiatrist's Bible, doesn't currently include things like porn addiction or sex addiction. It says that those repetitive behaviors, or those behavioral addictions, things like sex addiction, for example, or shopping addiction, aren't included at this time because there's basically insufficient peer-reviewed evidence to establish a diagnostic criteria.
You'd say that they were compulsions or addictions, basically.
I'd say that they were, yeah, and I'd say that really for quite a practical reason, because if you've worked with anyone or you know anyone who's a compulsive user of porn, for example, and that they use pornography for hours on end, often even though they hate having done that and hate themselves for having done that and hate what it's doing to their relationships and long to stop. I don't really know what else you'd call that. So I'd call that an addiction.
Okay, so given the frequency and the availability of things like the internet and porn, are we saying that anyone can get addicted to those given their availability?
No, I don't think we are quite saying that, interestingly. So I think most people who, if you take an example like opioids, so most people are exposed to opioids. So if you're thinking about something like morphine for pain relief in hospital following surgery, most people don't in fact become addicted. And you can think about that in quite a common sense way. When people come out of hospital, they don't continue to be addicted to that drug. And in fact, even when they're in hospital, about a third of people seem to find that kind of pain relief really unpleasant, and actually many of them can't tolerate it and ask for alternative forms of pain relief. So most estimates suggest that 80 to 90% of people who try heroin, for example, don't get addicted. And those numbers tend to come from studies of people, of vets coming back from Vietnam, for example.
Yeah, it's a high number, isn't it? 80 to 90% goes against what the kind of cultural expectation is of, particularly for class A drugs like heroin. We think if you try it once, you're going to get addicted, but 80 to 90% of people, that's a high number. And if we apply that to kind of our own experiences, our own personal experiences with something like alcohol or use of games, for example, I think a lot of people can decide when to have a drink. They can use it in moderation, and they can gamble at, say, a football match, but then never gamble again for the rest of the year. They might gamble at the World Cup every 4 years, for example.
Yeah, exactly right.
Okay, let's move on to causation. What do we know about what causes addiction? Does it have origins in adverse childhood experiences? And if so, what are adverse childhood experiences that are directly relevant to addiction and compulsions?
Yeah, so I think the short answer to that is yes, in part does seem to have an origin in those kind of adverse childhood experiences, and there's a lot of work now on those adverse childhood experiences. So there's a bit of skepticism in some academic quarters because much of that information is based on many of those studies are based on self-report information. But there's a recent study in the journal Nature, one of the most important scientific journals, and they found a really strong association between what they describe as childhood maltreatment and subsequent substance use disorder. So they say that more than 1/3, that's like 36% of those who are exposed to childhood maltreatment, and that's as evidenced from a medical record. So it's not self-report information, it's a documented instance of maltreatment. 36% of those who were exposed to childhood maltreatment ended up having some kind of substance use disorder, and that was compared to fewer than 6% in the control group, which is those who hadn't had any documented childhood maltreatment or any prior contact with child psychiatric services. So we get into a bit more detail on the nuance of the study in the course on addiction that we've got, but that's it in summary. They find a robust association between childhood maltreatment, or what some people think of as adverse childhood experiences, and substance use disorder, approximately a threefold increase in substance use disorder risk in individuals who've been exposed to childhood maltreatment. And there's a massive sample size, so nearly 30,000 people. It's a really important study, which is why I'm dwelling on it a bit.
Does childhood maltreatment always lead to substance use disorder, or are there other things involved, other variables involved?
Yeah, so I think a particular adverse event shouldn't be viewed as leading to the same outcome in every individual. I think that's the key point here. It should be considered in the light of the individual's characteristics. So things like temperament still matter very much. Who the child's friends are and what they're up to, whether they're a help or a hindrance in that young person's life, matter very much. So essentially, I think the key difference is whether there's a secure relationship really with an attachment figure in place, i.e. can the adverse event, can it be understood, can it be withstood, can it be buffered with the help and skill and concern and kindness of a caring adult. I think that's the essence of it.
Right, so we're starting to bring in the basics of attachment theory and the work of Bowlby and Ainsworth and other people here, aren't we?
Yeah, I think we are. And I think that's really essential. I think attachment theory is really essential in terms of offering a proper understanding of adverse childhood events or childhood maltreatment, however you define it, whatever kind of things immediately spring to mind, whether that's a parent using drugs, whether that's a parent in prison, whether that's the fact of a divorce, whether that's financial insecurities, whatever else those events might be defined as, and they do tend to vary a little bit. Most of those things can be withstood, understood, and buffered by the presence of a caring adult. And if someone doesn't have that person in place, very different outcomes.
And that partly helps answer that criticism that can get pushed back, which is, well, there's lots of people who've faced adverse childhood experiences, face stress, poverty, neglect, violence, who go on to get good grades, build successful lives, successful careers, relationships, and push back and say, well, this is just making excuses for people, the idea that the environment contributes to addiction.
Yeah, absolutely. So the key difference seems to be in something like the number of those events, how many of those events have occurred to you, there seems to be a tipping point. And then also the other key point, the one that you were just underscoring, has there been anyone who's helped you through them? Or in fact, has there been somebody around who's made those worse, who's spun out in their own life, who hasn't been able to cope with those things that are going off in a family, rather than putting an arm around a shoulder and offering care and kindness and steering the young person through that, actually has the impact in the adult's life becomes so great that they become part of the problem rather than a way of helping the young person, the child, navigate through that.
So as well as biological markers and influences, which I think is fair to say we don't yet fully understand, we're saying that the roots of addiction appear to be in early attachment and trauma.
Yeah, I think that is fair to say, and that's basically the self-medication model as well, the self-medication thesis, that addicts are probably best understood not so much as pleasure seekers or self-destructive characters, but as individuals who are in pain, seeking comfort.
So we've learned that addiction has a psychological purpose beyond just habit. It can be a coping mechanism. It can be a way of managing life, of relieving negative emotions, and for which real life connection increasingly becomes a poor substitute in comparison. In part 2, Matt, we'll look at the clinical implications of what we've been talking about here in part 1, how we can work best with addiction, and indeed whether we should be working with this condition, particularly if we've not had any personal experiences of addiction ourselves. Is there anything to add before we close part 1?
No, I think just to say, spoiler alert, in terms of that last question, you should. If you're a trained therapist, counselor, then I think that's the business you're in, and you can help in that situation. And we'll try and explain a bit more why we say that with such conviction, and the ways in which you can have confidence to do that in part 2.
Great. Don't be scared off.
Exactly.
See you in a bit.